My name is Martin Gaynor. I hold the position of E.J. Barone University Professor of Economics and Public Policy at Carnegie Mellon University. And in 2013, 2014, I was the director of the Bureau of Economics at the Federal Trade Commission, the chief economist at the FTC. So I was responsible for all economic analysis and opinions at the Federal Trade Commission during that period. My research is on economics of firms, markets, competition, antitrust. Much of it is focused on healthcare, where there are certainly a lot of issues, as I'm sure we'll be talking about very soon. I've been working on these issues for almost 40 years now.
You don't look a day over 35, Marty.
More.
This one's a little different, I think, than the others because it's our brief, together. So we'll just have a conversation. So I think tell me about the topic, like what you and I are looking at in this brief.
Right. Well, this is something that, in my view, and Zach, I think we agree on this, is one of the most critical issues facing U.S. healthcare. But ironically enough, it's one of the things that gets the least amount of attention from policy analysts and from policymakers. I'm not quite sure why that is. I think that a lot of policy.
And this is like consolidation and changes in market structure.
Yeah. And so what we focused on, Zach, you and I in this brief, are issues having to do with the functioning of healthcare markets, hospital markets in particular, and how that functioning has really been seriously impaired.
So why do you think they're working poorly? What are the sort of the problems here that we need to fix?
Right. Well, there's a whole laundry list of problems, but one of the most basic problems is lack of competition. These markets can't work well if there isn't competition. Now, that's not to say that if there is competition, they're going to work like the markets for retail gasoline or milk or pencils. But we have lots of research evidence over years and years that shows that they do work better when there's more competition. When there's more competition, hospital prices are lower. When there's more competition, patient care is better. Health outcomes for patients is better when there is more competition. There's evidence that there's more innovation and flexibility and better service when there's more competition. So less competition is not a good thing in the system. And what's happened over time is that many, many markets, I'd say actually the majority of hospital markets in the US, have become less and less competitive. And you know why that is, Zach.
Mergers and acquisitions. I mean, just this wave of consolidation that's happened over the last 20 to 30 years.
Yeah. Well, over the last 20 years, actually 20 years exactly, we've had almost 1,600 hospital mergers. That's on a base of a little less than 5,000 starting out that period. And what do we get? We get higher prices. And who pays for those higher prices? Well, you might say, so hospitals charge private health insurance companies higher prices. Why should I care? I don't even like private health insurance companies. Well, that's right. They do. And the insurance companies' expenses go up. Do they bear those costs? No. Those get incorporated in higher premiums that get passed on to people purchasing insurance, who mostly are employers who are providing insurance for their employees. Well, you might say, okay, I'm not so happy if my employer has to pay more, but why should I care? What does it matter to me? Well, it turns out that what happens is workers end up paying for this. It's a very indirect chain. And this is one of the things about healthcare that makes it hard to understand and makes it hard to see how competition works here. But at the end of the day, workers do not get pay increases, or they pay a larger share of the healthcare costs, or they get less generous health insurance policies, or some combination of those things. And so it comes right out of their wallets.
Yeah, no, I could not have said it better. So I guess then the question is, what do we do about it? I think you and I both agree on the problem. Frankly, we both agree on the solution. So we put forward a couple steps. Do you want to describe the the interventions we're recommending?
So we have how to reinvigorate healthcare competition in 5 easy steps.
There you go. It's a
One,
cookbook.
Step one, provide adequate funding for the federal antitrust enforcement agencies. That's the Antitrust Division of the U.S. Department of Justice and the Federal Trade Commission. So people may not know this, but their budgets are actually relatively small. They're a very small proportion of the total federal budget. And those budgets have not increased, adjusted for inflation, for years. Now, at the same time, there has been a huge increase in the number of mergers in the US economy. So mergers have been going like this, and the budgets of the Department of Justice, Antitrust Division, and Federal Trade Commission have been like this, or maybe even declined a little bit. So they need a really big boost in their budgets just so they can keep up. And I'm only talking about horizontal mergers between, say, hospitals and hospitals, not even other kinds of things that are serious concerns.
And there's return on investment in that funding, right? The mergers that they block are in a sense, dollars saved for the economy. Because one of the things that happens is when healthcare costs go up, the dollar of wages that don't get taxed, because those dollars are health insurance dollars are paid for using tax-free money.
100%. I think that's an important point, Zach. So you spend a few $1,000,000 more on antitrust enforcement, you stand to gain millions and maybe even billions more.
So issue one, more money.
We've only gotten to
more money for antitrust agencies.
So two, this also might seem a little surprising to people, but the Federal Trade Commission, which is charged with enforcing the antitrust laws in the United States, is prohibited from investigating and prosecuting anti-competitive actions by not-for-profit firms. They are permitted to go after mergers. So if two not-for-profit hospitals merge, they can go after them. But if two not-for-profit hospitals engage in illegitimate tactics to try and keep others from competing with them, ambulatory surgery centers or clinics or physician practices, or if they collude, the FTC is not permitted to go after them. The U.S. Department of Justice can, but not the FTC. So we only have half the power of antitrust enforcement in the U.S. on these kinds of things, and that doesn't make any sense. So,
nonprofits are what, 60%, 70% of hospitals in the U.S.
Right. It's the vast majority of hospitals, and so now we're asking the Department of Justice to carry all that burden, where we could and should, in my view, and both of us agree on this, have the FTC involved too. And the FTC, as a matter of fact, is the agency that does most of the work in the hospital sector, so they really have the expertise. And I, of course, have tremendous respect for the Department of Justice, but the FTC is the agency that really has expertise. So they should be able to do that. So that's a very, very simple fix. So that's two. Three, introduce what's called site-neutral billing in the Medicare program. So again, this may surprise people, but Medicare's a very complicated program, and they have to make all kinds of decisions about how they're going to pay for things. So one thing they did a while ago was the following. They said, well, if a visit to a doctor is provided in a hospital setting, then they would provide an additional payment on top of the usual payment for the physician care, because it's in a hospital setting and hospitals have higher costs. Well, what that means is if there's a physician practice and they're independent, they get paid one amount. If that physician practice is owned by a hospital, they get paid that amount plus this big bump, and it's a big bump. And so this exactly the same thing is being done. Same patient, same care, same doctor, but if that practice is owned by a hospital, a substantially higher amount being paid. So it turns out, not surprisingly, it's very profitable for hospitals to own physician practices, and it's profitable for physician practices to be owned by hospital, because that additional payment can then be split between the practice and the hospital. And there's also research evidence that shows that, yes, this has provided a big incentive for the acquisition of physician practices and hospitals. And there's been an avalanche of this. We were talking earlier about all the hospital mergers, hospital. But one of the biggest things happening in the past few years has been an avalanche of acquisitions of physician practices by hospitals. And this is part of the problem. It wasn't intended. It's not why the folks at Medicare did it. And Congress went part way towards fixing this problem, by the way. But they can easily just go the rest of the way. And you just get paid the same amount. It doesn't matter what kind of setting is it. Independent physician practice, practice owned by a hospital. It's the same care. It really has the same cost. It should be paid the same way.
All right, issue 3. What is intervention 4?
Intervention 4, strengthen antitrust enforcement laws. Now, this is a whole array of things that I don't think we have the time to get into extensive discussion. But what's happened over time, for a variety of reasons, is it's become harder and harder for the antitrust enforcement agencies to win lawsuits in court. And it's gone to the point where the deck is stacked against them to a certain extent. So there are a number of people who've been working in antitrust for a long time and are very experienced and knowledgeable, have been calling for changes to change the standard for judging whether, say, a merger is anti-competitive, to expedite things, honestly, to take some of the discretion out of the hands of courts. Now, we have great people in the courts, but let's be clear on how this works. If there's a lawsuit and it goes to a federal judge, that judge will be hearing an antitrust lawsuit, say about healthcare, and that judge has no particular expertise in antitrust. They have no particular expertise in healthcare. The day before, they were hearing something about racketeering. The day after, they're hearing something about federal drug charges. And of course, they're great people, but they often can be influenced by specious arguments. And the defense has had the advantage in antitrust cases for a long time. And this affects not just what happens in courts, but what kind of cases get brought in the first place, and whether a case gets brought, and how many. And so in my view, and I believe we share this view, there's been 100%. Under enforcement. So there are a number of relatively simple fixes there that we're suggesting be followed that will benefit the economy generally, but healthcare specifically.
Perfect. Recommendation number 5.
And last, this is also a very simple recommendation that we have. So a lot of mergers that happen in healthcare are pretty small. So think about, say, 2 physician practice. Think about the practice that your physician is. For many of us, the physician is in a practice with 3 people, 4 people, 5, generally. Not real big, some even all on their own still. So if you have 2 of these practices merged, they're very small. Or practices are acquired by hospitals. They can also be considered small acquisitions. Now, it's not required that every single merger and acquisition be reported to the federal antitrust enforcement agencies. Only required if the value of the acquisition is above a certain level. So really big mergers, like say 2 airlines merging, of course those get reported. And then the agencies have a chance to take a look and decide, well, does this look great? Does it look benign? Does it look harmful? But there are lots of these mergers that are underneath the radar. They're not reported. So the only way the Department of Justice or Federal Trade Commission know about them is if somebody reports it to them, they find out in the newspapers or some other way. So what we're saying is just very simple. Have reporting on these mergers. Have a very simple form they can fill out. It doesn't have to be lengthy. It doesn't have to be difficult. But make sure that the agencies know about these things so that they can at least keep track of what's happening. And if there are mergers, these relatively small mergers that really do seem like they're problematic, they're going to harm competition and harm consumers, they can investigate. Right now, they are flying blind. And as I said, there have been huge numbers of mergers that fit this description.
I agree. I think we've seen the physician market in the US pretty radically reshaped, really without the lights on the dashboard starting to blink red. I think because many of these deals were just under reporting thresholds.
Right. So this is a very simple thing. And if you think about the 5 things that we're talking about, none of these are complicated. None of these are big deals. Even large increases in budget for the enforcement agencies don't add up to a big bill for taxpayers. They do not add up to a large increase in the federal budget. These are very simple and straightforward, and we think they could be done very easily And you and I agree, they could actually make a big difference. As you said earlier, Zach, they would pay for themselves many times over.
And so let's sort of give the back of the envelope estimate of savings. I mean, obviously hard to do in this case, but given the scale of the hospital sector, I think we can put some dollars in there and just sort of say, look, this is the scale we're talking about.
Yeah, so that's a really good point, Zach. And one thing that people should know is the following: the hospital sector is huge. So it's over $1 trillion, or it was over $1 trillion spent on hospital care in our country in 2018. I'm sure it's even more now. That's almost 6% of the entire economy. So it's one of the biggest sectors in the entire economy. So a small percentage change adds up very quickly. So the kinds of things we're talking about, I think you and I agree, could save at least, say, 1%. And that 1% reduction, just for people who are privately insured, not for people who are Medicare or Medicaid, would save $5 billion a year. I'll take it. If nobody else wants it, I'll
Okay.
take it. If it's more, say if it's 5%, which I think is plausible. I think we both think that actually is something that could happen. 5%, we're talking $25 billion.
Right.
So that's a big difference, and that's just initial sort of one time savings, not one time, repeated savings, but just from these things. What could also happen is you start making these changes, you initially get some savings, but they set in motion a number of things that really change the way the hospital sector and the healthcare sector works. And if that's the case, then it could save substantially more money than that.